Okay, I hope I'm audible and okay, it doesn't matter if I'm visible or not. So shall we start? Hope all of you have your articles with you. Let us start with um, school reopening. Yes, live done, ma'am. Yeah, I saw that, Dr. Sam, but just now I realized that I was actually live. I was unable to open the YouTube. Right. So let's start with school reopening. All of you have your articles open? Right. So if a question on school reopening is asked, this is how you are going to start. You will start saying that this pandemic has resulted in loss of learning, resulting in up to 50% of decrease in academics. This loss of academics will result in depression, will result in anxiety, and will result in post-traumatic stress disorder in children who have undergone this period. Where schools earlier provided a safe and stimulating environment now has become a risk. These are the three things in your introduction. So to overcome these factors, Indian Academy of Pediatrics came up with guidelines for school reopening. What does the guideline address? Three things. Come down to objectives. In objectives, there are three things. To recommend how and when should the school safely be opened, to describe various ways and means of remote learning, and what are the contents of learning. So when should you open the school? How should you open the school? And if you are going to open, how the learning will be, and what the contents are that you're going to teach to students. So these are the objectives. Skip the process. Come down to the guidelines per se. Okay. Page number 4. Guidelines. When to reopen school. The factors considered before reopening schools are two. One, children per se are at lower risk of having complications secondary to COVID. But on the other hand, they can develop infection and they can be a good spreader. And especially where there are multiple children clustered in the same classroom, there is increased chances of spreading to one person to another and then going home and spreading to their family members. So keeping this in mind, they came up with 3 epidemiological characteristics. Next page. So these characteristics are applied at a district level. This is very, very important. Okay. So what do I mean by district level? The decision whether open or not open, schools should be taken at a district level. It's not at state level. It's not at national level. It should be at district level. And what should the districts look at? The epidemiological characteristics. They should have steadily decreasing number of new cases of COVID for 2 weeks. All duration of 2 weeks. Okay. 3 epidemiological characteristics. All are of 2 weeks duration. One is steadily decreasing number of new cases. Second one is case positivity rate should be less than. It does not say pediatric or adult. Okay. It's overall. The case positivity rate means among the total number of COVID-19 tests they have done, only 5% have come positive. That is case positivity rate. It should be less than 5. And number of new cases in the district per lakh population per day should be less than 20, again in the past 2 weeks. So with these 3 epidemiological characteristics, if they are satisfied, then they can consider reopening the school. And before reopening the school, what are the things they should consider? These characteristics are satisfied. What about the school? Does the school have infrastructure? Does the school have teaching staff? Does the school have enough health and hygiene facilities in place? These are the 3 things. Okay. So 3 characteristics, 3 things for school to open in place. Next, B, how to reopen school. Now, when to reopen, we saw. How to reopen school. In how to reopen, there are 2 phases. One is a preparatory phase where before you open, you put certain things in place. What we discussed, your infrastructure, your members, and your health and hygiene. These 3 things should be in place. And second phase is your actual reopening where you implement and you modify things if needed. So in preparatory phase, you do a policy making. Okay. So policy making, school administration will designate a responsible staff who will draw up the policies that are going to be implemented once the school reopens. The policy of staying home if not well, that is the last line in the page. Okay, that should be in place for everyone. By everyone, they mean everyone, not just students. It means teaching staff. It means non-teaching staff who are supportive. Everybody. If somebody says they are not well, they are supposed to stay at home. So this is policy making. What is the infrastructure change that you are going to bring in? Infrastructure change, whatever building is there has to be cleaned and sanitized, and hygiene rules has to be kept in place. And wherever common areas are there, where people will commune together, all of those should be airy and well ventilated. No AC should be used. All right. It should be airy and well ventilated. And reception area should have a plexiglass guard. Toilet facilities should have free flowing water and it should be amply available. There should be a specific sick room that is designated in case somebody becomes sick during their stay at the school. So this is about the building. What about the staff, parents and students? They should be given ample information. Whatever information you know, your mask, your distance, your hand sanitation, these three things should be taught to everybody. Your cough etiquette should be taught to everybody. This is about staff, parents and students. And they should encourage routine vaccination of children before coming to school. They do not mean COVID-19 vaccination. Your routine vaccination, including influenza. If you have a COVID vaccination, yes, take it and come to school. So this is about capacity building. So in preparatory phase, three things they will do. What they will do? They will make a policy. They will make the infrastructural changes that are necessary. They will make sure the staff are completely educated on what needs to be done and what does not need to be done. So this is before opening. After they open, what are they going to do? They will put in measures for physical distancing in classroom. How are they going to bring about physical distancing? They can actually move the benches away. They can ask students to come in batches. They can ask students to go in shifts. These are different things that can be done. So what is advised is they will open in batches with older students joining first. They will be asked to come few people in the morning, few people in the night, or on alternate days for a different set of students. So they will have a staggered entry into school and it will not be overcrowded. And where they are going to stay will be well ventilated. And outdoor spaces should be preferably used. Distance of 1 meter should be applied. And your gym, locker space, these are the places where students will crowd together, go for a snack, go for some talks, small talks. So these areas should be well ventilated and preferably will be avoided. They will preferably not have their lunch snacks in school. Okay, so it should be minimal. Whatever things they are getting to school should be very minimal. It should not be too much. And visitors should be restricted. Co-curricular activities mean group activities, team sports, all of those are discouraged. Anything that accumulates students in one place should be discouraged. What about precautions during commute? Again, school buses, after every trip, they have to be sanitized before picking up a new batch of students. Whatever staffs are there, the driver, the person who's going to help, all of them are supposed to wear masks, practice hand hygiene, practice cough etiquette. Maintaining sanitation and hygiene, again, the same thing you're going to repeat. Okay, so let's look at the implementing phase once again. In implementing phase in classroom, what are you going to do? You're going to make sure they are well spaced. You're going to ask them to come in batches and you're going to ask them to practice avoiding overcrowding and good hygiene practices like mask, hand sanitizer. And when they are going back home, the school bus should be clean. And in between, no lunch break, no snack break. These are the important things. And no PT period. Okay, no co-curricular activities because again, overcrowding. Then screening and management of sick. In case somebody becomes sick, how do you identify anybody who is feeling feverish or anybody actually having a temperature of 99.4 degree Fahrenheit or above should be denied entry in school. Not just students, the staff members also. And testing should be conducted in every suspected person. Suppose somebody becomes positive, they have to stay at home for 14 days and the school officials will extend full cooperation to government protocols like contact tracing, testing, isolation, etc. This is screening and management of sick. Next is remote learning guidelines. So what we saw from beginning, what we saw was why they wanted to have the school reopening guideline and what are the characteristics of when to open, then how to open we saw, then when they are going to open, before opening pre-implementation guidelines and during implementation what they are going to do, and what about remote learning. Remote learning per se can be asked as a short note, I felt. Okay, so remote learning is defined. The first line is the definition. The learning process where students are not in physical proximity to the teacher, as against classroom teaching where they are going to be in proximity to each other. Okay, so this can be put in another way, where they are separated by time, space, or both. All right, why do I say time? Because it can be a distant learning, like now we are seeing live each other, so this is like live interaction. But suppose I have pre-recorded and posted a video, then again we are separated by time. I might have recorded it at 1 o'clock in the night or early morning, but you might be seeing it at 6 a.m. in the morning, so that's distanced by time. All right, and obviously we are distanced by space. The classification of remote learning is like this. It can be a print or a non-technology, and the second one is technology. Okay, print or non-technology and technology. Oh, you want me to be a little bit slow? Then we may not be able to complete all four. That's the reason. All right, I'll try to go a little bit slow. Let's see. So in non-technology, it is correspondence course, where I send you a set of material, you sit at home, read, then I'll send you a set of questions, you will answer it back, and I will give you marks. So that is non-technology or print-based learning, which is correspondence. What about technology? Technology is divided into two. One is electronic and the other one is digital. Electronic is your TV and your radio. All right. So for TV and radio to be effective, the government should put in place the cable connection to reach everywhere. The radio, your waves should reach everywhere to every part of the country. So that can be used as an education medium. Digital is what is most being pushed right now. Digital is what we are doing right now. All right. So it can be a massive open online course, or it can be an individual one-to-one based, or it can be a pre-recorded thing that is posted at regular intervals. So these are the classification of remote learning. So remote learning is teaching learning process where the student is not in proximity to the teacher. They are separated by space and time. It is classified as technology and non-technology. Non-technology is print or correspondence course. Technology is divided into electronic and digital. Electronic is your radio or TV, and digital is your massive open online communication, your individual one-to-one teaching, or pre-recorded lectures that are posted via an app or YouTube or Facebook or whatever media. It can be asynchronous or synchronous. This is what we discussed. What we are doing now is synchronous, where we can have an interaction. You can tell me in chat that I'm going fast or I'm going slow. So that is synchronous. Asynchronous is where I put a pre-recorded video. I will not be able to have a live interaction with you, and you will not be able to have a live interaction with me. So this is classification of your remote learning technology, you can say, or remote learning per se. Then come to the next page. The 9th page has your Pragyatha guidelines of Government of India. This describes the various ways of imparting distance education with the help of technology. That is one line that you need to know. This is the important points in remote learning. Hybrid learning is where you combine both remote learning and in-person learning, and that is going to be the way forward. So now we saw how they are going to open, when they are going to open, then remote learning, how we are going to do, and last one, what are the contents that are going to be taught to the students. The National Education Policy 2020, which came, is stressing more upon practical life activities. Okay, it's more oriented towards Montessori, I would say, especially for younger kids, rather than concentrating on them to write A, B, C, 1, 2, 3. You teach them practical life activities, helping out parents in kitchen, helping out going for shopping, getting vegetables, fruits. So those are practical life activities. It's oriented more towards that, more towards informal education rather than a formal education. And it should be of less stress. So in COVID times, content of learning should not be stressed. It should be in an unstressful manner, and it should be more informal education rather than a formal education. Formal education is for older age groups, whereas informal is for younger age groups. So easing out on formal learning is important, and emphasis on informal co-curricular learning. Next page. Students are more likely to find such contents of learning interesting and easy to follow through. And one more thing that they state is, try not to give new things every time. Try to teach them the things that they have already learned, so that it gives them more confidence that, okay, I already know this and this is not something new. So it's not intimidating for the student. So how are you going to go about this? How are you going to reduce the academic burden of formal learning? 50% reduction in syllabus. Very nice to hear, no? We never had that. All right. 50% trimming in syllabus for all subjects of all classes. So there is a stress-free and appropriate learning. Revisiting and revising already covered portions. Formal learning only for graded subjects. What are graded subjects? Which are going to be given marks. Graded subjects. Okay, language, mathematics, science. So those are all graded subjects. And all teaching should be child-centered, preferably activity-based learning rather than textbook learning. It should stimulate them to think further and not just regurgitate whatever is being taught. And all type of learners should be facilitated. Who's hard of hearing, who's visually impaired, all of them should be, incorporated into the teaching process. And they can be evaluated intermittently. This is how they are planning to reduce the academic burden. And how are they going to give this academics to the students? Depending upon the age group. 3 to 6 years, as I said, it is informal, adaptive, playway learning. Next, reading should be introduced stepwise after 4 years. Pencil holding only after 5 years. No asking them to hold a pencil before they can actually grip it. Okay, this is being done very, very commonly. Even before they have the development of holding the pencil like this, you ask them to write A, B. You try to force them. So that should not be done. So reading at 4 years, pencil holding at 5 years, and even then it is only just knowing this is the alphabet and trying to write the alphabet and counting only few numbers. Students should be encouraged to assist parents in household work, home items based play rather than buying new things, and actively talk and interact with children. Parents and teachers both should be doing. This is for younger age group. Class 1 to 5, same thing, but slow introduction of formal learning should be done. Gross and fine motor skills should be encouraged. Early literacy and maths and language should be introduced. Upper primary classes, more and more independent learning and more introduction to formal studies. Secondary and senior secondary, they are more self-dependent, they are more responsible. Give them more responsibility to do their work. So that is what is called as the SMART goal. SMART goal. Page 11, last line, if you see, that is SMART goal. SMART is specific, measurable, achievable, rewarding, and time-bound goal. Should be given to students because they are older kids and they can be responsible for themselves. So if they require help, offer them help. If not, leave them slightly independent. And their curriculum should ideally be divided into must know, need to know, and will be good to know classification. So this is about your curriculum that needs to be given to students. And you can promote co-curricular learning. You should empower the caretakers, the parents or the caretaker who is going to be taking care of the child, to help the child learn through this remote learning process, because this is new for everybody. That's it about school learning. Rest everything is references. Before exam, you can try to revise yourself going to the last 18th page, 19th page. If you see, there are few boxes. Okay, so whatever we have learned, they have given in a box shaped manner. You can try to go through that. That can also be done. And technology based remote learning, they have given points. So if they ask a question like that, then you can easily write it. So that's it about your school reopening. So shall we proceed to the next question? Umbilical cord banking. Let's go to umbilical cord banking. Umbilical cord banking, I already have put up a video, so you can go ahead and read that. But let's go through this article quickly. It's basically from this article. It's nothing new. So all of you have your umbilical cord banking article open. Shall we proceed? Are they exporting another? I will proceed. Otherwise, I will not. All right. So umbilical cord banking. So if they, I think they have already asked this question, and if they are going to repeat it again, say that umbilical blood was once considered a waste product, but it is a rich source of hematopoietic stem cells, okay, which can be used as a fully or partially HLA matched donor. So that is the importance of umbilical cord blood. Next page, characteristics of umbilical cord stem cells. Okay, two important points in umbilical cord stem cells. One is they are stem cells. So they have got good regeneration potential, multiplication potential. All right. And because of this self-renewal, they can stay on for a long time. And same thing, they have the capacity to differentiate into myeloid. They have the capacity to differentiate into lymphoid lineage. So this is one point. The second point being, they are naive of no, how do I tell this? They have naive T cells which are very innocent. They have not yet been exposed to the good and bad of the body. So because of this, they do not have the risk of having a graft versus host response when you're transplanting this umbilical cord blood. Okay, so these are the two characteristics. One is it's a stem cell, so has got good regenerative potential, can differentiate into lymphoid and myeloid lineage. And two, because of the presence of naive T cell, they do not have the risk of having a graft versus host disease. This is the characteristic. Cord blood banking, how are you going to collect? So you will collect it from the placenta during the third stage of labor or immediately after delivery. This does not pose risk to the mother or baby. It should be collected from umbilical vein. It is vein, not artery. Okay, it should be in a sterile closed system containing anticoagulant solution. Just because, just a second, Dr. Malini. Yes, I think this will be recorded and directly coming on YouTube. But as I said, I have not done this before. So hopefully it will come. Let's see. Right. So umbilical vein, it should be collected. It should be collected in a sterile closed system with anticoagulant in place. This blood will flow by gravity. All right. It will not be pushed or pulled. And it should be done only after umbilical cord clamping is done. Clamping should not be done earlier just because you want to collect more cord blood. That is unethical. All right. So after this is collected, it will be tested, it will be processed, and it will be cryopreserved. It can be cryopreserved for up to 15 years. And it can be used as and when the indication arises. Then umbilical cord blood transplantation. So here the importance is only 25 to 30% of who actually require an allogenic transplant are able to get a transplant. This umbilical cord blood cell, it overcomes the step of having a HLA matched this one. All right, because it's going to be naive. It does not have a risk of graft versus host disease. So it's very good. Having said that, the stem cells may not be in adequate number. So it may not help very bigger kids or adults. But now that is also being slowly overcome by doing double cord transplantation. Next, coming to public versus private cord blood banking. Okay, so in this, you need not go through all of the paragraphs. There is a nice table that is given in page 4. Okay, so go to page 4. You will see a nice table differentiating private versus public cord blood banking. So basically, it is this. Private means, say, if I am the mother, I will put my baby's cord blood into the private bank and I will pay them to keep the cord blood safe. All right. And I will not allow that cord blood to go to anybody. It will stay in my family. That is private blood bank, private cord blood bank. Public cord blood bank is where I store my baby's cord blood in the bank. I do not pay anything to the bank. If somebody requires a transplant and their blood is HLA matched against my baby's, then they can request the bank to give to them. And they will be paying the public bank to take the stem cell. So I will not be paying anything. The receiver will be paying the money. So public bank stored cord blood is available for worldwide use or nationwide use, at least, if not worldwide. Whereas private is not useful for everybody. So what do you think is better? It is always public banking, which is better. So private bank, family opting to store blood pays, profit, aggressive marketing is the aim, beneficiary only to the donor of the cord. Public bank is public funding, non-profit. The receiver is going to pay. Inventory of cord units for unrelated use is present, available to matched recipients nationally and internationally. So this is about private versus public cord bank. Now they're coming up with the concept of hybrid banks, where you will store it privately, but if somebody needs it, they can approach the bank and ask to be donated. And if you agree, the cord blood will be donated to the whoever requires it, and your money will be refunded. Okay, so this is hybrid model. Page 4 is in your umbilical cord blood banking guidelines of IAP. Page 4 table. Right. So this is about public versus private. Facts and myths of private cord blood banking. You need not use the same topic. You can say the importance of cord banking, and you can say these points. The points are these. Cord banking is rarely used for the same person who has actually stored it. Okay. The reason being, most of the indications are hematological malignancies. It can be storage disorders. Okay. Or it can be a hematological disorder like thalassemia. These are the three places where a transplant might be required. But having said that, if suppose I am going to have a malignancy, the malignant mutation is going to be there in almost all my cells. So I cannot utilize the same cell that I have stored for me. That's not going to help me in any way, right? So autologous use does not help in malignancy. Similarly, in storage disorder, it's usually genetic, so same stem cells cannot be used for me. And hematological disorder like thalassemia, again, the same thing is going to be there in my stem cells, so I cannot use the same for me. So the parents should be educated that this cord blood is not going to be useful for the same kid. It might be useful for somebody in the family. Okay, so you can store those sort of cord blood in private banks, because you know obviously that you're going to be using it for one of the siblings or one of the close relatives for a needed indication. But otherwise, public banking is always best because it's widely utilizable. Is that a word? I don't know. But yeah, so many people can utilize it. So these are the facts about uses of umbilical cord banking. So same person cannot use it. And another thing, it's not that good for a hematological malignancy. The reason being, if you are going to give an allogenic transplant, the importance of allogenic transplant is that will have a graft versus leukemia effect. So whatever graft you are going to give is going to fight against the leukemia cells. Since the cord blood cells are going to have naive T cells, they cannot fight against the leukemia, hence no graft versus leukemia effect. So not so good for hematological malignancies. So that's it about uses. The disadvantages being the small number of stem cells, then not having a graft versus leukemia effect, and the uptake time is more. Okay, so the engraftment time is more compared to that of your bone marrow, regular bone marrow transplant. Then stem cell therapy is a speculative field. I think those are not required. Future prospects, we discussed hybrid model. That's it. That's all about umbilical cord banking. In last page 4, they have given IAP consensus. If you want to revise quickly, you can go through that. The points that we discussed are given in a single table. So this is about your umbilical cord banking. So ready to go to next one? Are you guys ready to read constipation? I think only this much we'll be able to discuss. HUS, let us discuss day after tomorrow. So are you guys ready to discuss constipation? Constipation, again, there is a video that will discuss in total about constipation. Here we'll be discussing only from the article. Okay. Hope all of you have the article open. So the first page, you have an introduction sort of thing. In introduction, you can write the percentage of functional constipation that comes to the practitioner. 30% of gastroenterology practice, and 4 to 5% of all referrals to gastroenterology, and 1% of general pediatricians see functional constipation. Okay, just say 30% of gastroenterologists and 1% of general pediatricians see functional constipation. So what is functional constipation? Come to the next page. There are multiple definitions. These definitions are important not just for theory, it's also for your practical OSCE Viva, it can be asked. So what is normal stool frequency? Only if you know what is normal, then you will know abnormal. Indian data is less than 1 month of age, 3 to 4 times per day is normal. 1 month to 1 year, it is 1.5 to 2 times per day. 1 to 2 years, it is 1 to 2 times per day. And more than 2 years, 1 time per day. The common age that we see is after 2 years. Okay. After 1.5 years sometimes, but mostly after 2 years. So remember, 1 time per day is the usual norm for Indian kids. So what is constipation? Constipation can be defined as a delay or difficulty in defecation sufficient to cause significant distress. If it is less than 4 weeks, it is acute. If it is more than 4 weeks, it is chronic. Okay. So delay or difficulty in defecation to cause distress. D. Delay, difficulty in defecation causing distress to the patient. Okay. So 4 Ds. What is functional constipation? Come down below. There is a box 1. All right. The same page, there's a box 1. Duration of more than 4 weeks. Okay. Along with, among 6 criteria, 2 should be there. So how can you remember that 6 criteria? So frequency of less than or equal to 2 per week. Okay. So that is first. Then when they pass that 1 or 2 times in a week, it is hard stool and it is painful for the child. It's a large diameter stool. And this child, because of this hard stool, is having overflow incontinence more than 1 time per week. And you're going to ask history. And mother says child stands in one corner and has this twisting of legs. I think he's trying to pass stool. But your interpretation should be child is trying to retain stool. Then you're putting your hand on the abdomen and you're feeling a hard fecal mass. So these are the 6 criteria. So what did we see? Less than or equal to 2 per week frequency. When the child is passing, it is hard and painful. It's a large diameter stool and this child is having overflow incontinence of at least more than 1 time per week. You're asking history. There's history of stool retention and or retentive portioning. And when you're examining, you see a hard fecal mass. Okay. So this is your 6 criteria. Among this, if 2 are there, it is enough. What is the importance here? Does not matter if the child is passing daily stool. Does not matter if the child is passing alternative stool. If the stool is hard and if the stool is painful, you are feeling a mass, it is still constipation. You got my point. So frequency is not important. And this point about large diameter stool, see in Indian setups where Indian toilets are being used, you may not have this difficult to flush large diameter stools. That history may not be typically there. It is more applicable in Western toilets, okay, not in Indian toilets. So that is one point that you have to remember practically. So this is your definition. So in introduction, you will write constipation definition. You will write about the number of children you see with functional constipation in your practice. Okay. So what is fecal incontinence? Fecal incontinence, just above the box, you have that. Fecal incontinence is the term that is supposed to be used, not soiling, not encopresis. Those are not the terms that you use in functional constipation. Okay. So you will use fecal incontinence. Fecal incontinence is of 2 types. One is retentive fecal incontinence. Second one is non-retentive fecal incontinence. Retentive is associated with constipation. Okay, where surrounding the hard stool, you have percolating of the liquid stool material and it comes out even without the child realizing. Non-retentive fecal incontinence is where there is no constipation, but still the child is having soiling. Okay, and normal anal sphincter tone will be present. This symptom might last for more than 2 months in a child with the developmental age of more than or equal to 4 years. This is important. It's not chronological age. It is developmental age. Remember that. Okay. So this is developmental age of more than 4 years. Refractory constipation is child is on treatment, optimal treatment, child is taking very sincerely, but still the constipation is not resolved after 3 months. Then it is refractory constipation. These are the different definitions. History and examination. Okay. So if any question is asked on say syndrome or say this sort of a clinical presentation, if they are going to ask, always remember HEIT. These 4 things should be covered. What is HEIT? History. E is your exam. I is your investigation, and T is your. So all these four things should be covered whenever such a clinical picture is given or a specific disease is asked about. So all these four are important from a clinical point of view to write in your paper. Right. So as far as history is concerned, what is your concern? You have to make a diagnosis of constipation. You have the definition for that. So you will ask questions related to that. Then you have to differentiate between functional and organic constipation. What is organic constipation? Something else is causing constipation. What is something else? I mean something like a Hirschsprung disease, something like a hypothyroidism, or something like a spinal disorder that is causing constipation. Okay. So you will ask for history pertaining to organic constipation. Then you will look for precipitants of functional constipation. What are the precipitants? If you see the third paragraph, important precipitating factors of functional constipation, you will see that premature initiation of toilet training is one of the most important factors. Okay, so it should be started only after 2 years, not before that. And if there are any drugs, it can result in precipitation of constipation. If the child has had an intercurrent illness, if the child is having an abrupt transition in diet, abrupt transition in environment. These are the precipitating factors for a functional constipation. Then you will ask about dietary history, because diet is a very important component. You know that if the child is going to be on exclusive milk-based feeding, then the child will end up with constipation. This is the most common cause of functional constipation, perhaps, in India and what we are seeing. So minimal solids and more of a milk-based diet will result in constipation. Lesser dietary fiber will result in constipation. Less fruits, vegetables, refined and more refined foods. All of these can result in constipation. So you will ask for this history. Examination, what are you going to do? You are going to palpate for fecalith. You will do a digital rectal examination only if indicated. Otherwise, you are not going to do. You can differentiate between your functional constipation and your Hirschsprung disease. How will it differentiate? You will actually palpate fecal mass in a functional constipation, whereas in Hirschsprung disease, it is going to be empty. And when you remove your finger, there's going to be a gush of stool that is going to come out. And this is the table where you have functional and organic constipation, clinical features and interpretation. This is pretty straightforward. I think all of you can go through this easily. Then red flag suggestive of organic constipation is important. Same page, page 887, lower down you will see that. If there's a delayed passage of meconium, onset of constipation is very early in infancy, ribbon or pellet-like stools, if the child is having a bilious vomiting, abdominal distension, failure to thrive, recurrent lower respiratory tract infection, all of these are red flags suggesting that it is not functional. The child is having some other problem. Okay. Investigations wise, nothing is needed. 95% of children do not need any investigation. But if they fail to respond to your therapy, then they need to be investigated after referral to your gastroenterologist. Management. Management wise, patient counseling, your toilet training, your dietary advice, and your softening of stools therapy. Okay. So patient counseling, you will tell them this has caused the constipation. This is how you're going to take care about it. Second is toilet training. Advise them the rule of one. Toilet training is rule of one. One person will do the toilet training. One routine should be followed, like 5 minutes after feeding or 30 minutes after feeding. All right. So that they will sit on the toilet. So that is second one. And another one is one word. One word to represent toilet. It can be kaka, it can be popo, it can be poop, it can be anything. Okay. So one word for in telling that the child is going to have or wanting to pass to, and in one place. The place where they want to pass stool should remain same. Okay, so they get more acclimatized to the concept of having to pass stool. So this is rule of one. Next, diet, fiber and water intake should be advised. Daily fiber intake of at least 0.5 gram per kg per day is important. Tell what are the fibers that needs to be given, and what should be avoided is bakery foods, refined foods, your continuous cow's milk intake. Increased semi-solid food should be given. Next, fourth one is medical therapy. So first one is patient counseling. Second one is toilet training. Third one is diet. Fourth one is your medical therapy. Medical therapy, two things are there. So one is you disimpact the stools. Disimpaction is very, very important, not just initiation of maintenance therapy. So disimpaction will actually remove that hard fecal mass that is present in the lower end of the intestine. So disimpaction can be done by two methods. One is admit a child in the hospital and do a hospital-based. Second one is home therapy. Both of them use the same medicine, that is polyethylene glycol, PEG. Both with electrolyte and without electrolyte are equally effective. So, and through oral route. It's not enema, it is oral route. Remember that. So, how much are you going to give? Next page has the table for disinfection. Just remember the dosage alone, nothing else is required. Dosage at home, you are going to give for 3 to 6 days. This is the first point. Okay, how much are you going to give? 1.5 to 2 gram per kg per day for 3 to 6 days. Okay, till the disinfection happen, till the effluent is clear. In hospital, it is going to be 25 ml per kg per hour for 4 hours. Okay, so this is hospital. It is per hour through nasogastric tube, or if they are able to take orally, then orally. Okay, so 25 ml per kg per hour oral or by nasogastric tube till the effluent is clear. It usually takes 4 hours. This is disinfection. Hospital-based disinfection has 100% success rate, whereas home-based has a lesser percentage. It depends on how well they take it. It can be anywhere from 70 to 97%. After disinfection, you will give maintenance therapy. Maintenance therapy, again, osmotic laxative and stimulant laxative, two varieties are there. Osmotic laxative is preferred. Among osmotic laxative, two things are there, polyethylene glycol and lactulose. Among these two, less than 1 year, it is lactulose. More than 1 year, polyethylene glycol is preferred. Never combine these two. Never combine two osmotic laxatives to be given. Okay. Then your stimulant laxatives. Stimulant laxative is your bisaccordal. It irritates and then makes the stool pass. It should not be used for maintenance therapy. It is only as a rescue therapy. Okay. So that is what is given in the next 3 paragraphs. Maintenance therapy, osmotic laxative is the mainstay of maintenance therapy. Polyethylene glycol and lactulose. PEG therapy is the first line. Less than 1 year, lactulose should be used. Similarly, dosage is given in the table 3 in page 5 or 889, whichever way you want to look at it. Okay. And behavioral therapy, biofeedback, if it is associated with behavioral comorbidity or pelvic floor dysfunction, you will guide them. Follow-up is important. It's not just enough if you give them treatment and ask them to say bye-bye. You have to call them back for follow-up at 2 weeks and assess compliance, see if it is disinfected, see if they are able to pass easy stools. Then every 1 to 2 months, then every 3 to 6 months can be done. Usually by 6 months, most of them would have improved and become good. When are you supposed to stop these laxatives? If they have been good for at least 6 months. Okay. So successful outcome is defined by 2 things. Successful outcome is stool normalcy while on laxatives for a period of at least 4 weeks of initiation of therapy. Second point is stool normalcy for a minimum period of 6 months before you start tapering. So after 6 months, for 6 months, if they have been good enough, if stool is normalized, then you can taper. Tapering should not be done abruptly. It should be done slowly. It should be done over a period of 3 months. Okay, so this is how you stop. Refractory constipation, something else is the reason, probably an organic cause, refer to a gastroenterologist. This is about your constipation. That's all we have completed. Next page, you have a nice algorithm. Whatever we have discussed, same thing is given in the algorithm. If you have read this once, you can just refer this and go to your exams. You will be able to write an answer on constipation. So I think this is enough. We have crossed too much of our time. We have taken nearly an hour to discuss just 3. Okay, I think we'll stop here. Toilet training and medical treatment, it should be done. See, if the child is just 1.5 years, you can't initiate toilet training for that child. No. Toilet training, some guidelines say even 3 or 4 years you can wait to toilet train. It all depends on the child. If the child is showing readiness, the child is able to say, I want to pass stools, then that means child is ready because child is indicating need. Then you can slowly initiate. Never force the child to do before the child is ready. Suppose the child is 3 years or 4 years or even 5 years, child is coming with constipation. Toilet training would have already been done. Isn't it so? Depends on the age. Younger age, do the medical treatment, see if there is no organic cause, then go about toilet training once the child is ready. In between this 2 to 4 years age group, simultaneously it can be done. And more than 4 years, it would have already been done. Toilet training, medical treatment is important, and try to find out what made the child to go into a constipation. Usually it will be a stress factor like changing schools or changing places or problems at home. So I think we will say bye-bye here. Let's see if the same recording comes in the YouTube. Hope this was helpful to you. If you need some other changes from me, let me know. I will try to do. This itself was like me trying to find out how to actually aim through YouTube and all. Acha, bye சொல்லிக்கலாமா நம்ம? Thank you, thank you, thank you. So tomorrow what we will be discussing, I will put up in the group. Tomorrow we will discuss question paper questions. Okay, so we will do that alternate day. So one day we will do questions from question paper, and another day we will do journals and guidelines. Because I think if you do that, that should be more than enough. Thank you, thank you. So bye bye, all the best, read well. We will meet tomorrow again.